So this is basically the point of it. Here's how you're going to fix your notes to make them more readable, probably bill higher, and get you out of some legal trouble. So first things first, identify discrepancies, okay? If you're writing a note and there's something that doesn't fit with the narrative that you're writing, address it, okay? The electronic medical record does not forget things. It is there forever, okay? If you had a paper chart, stuff can be erased, stuff can be scribbled through. Not so with electronic stuff. If a nurse in triage writes a note and puts the wrong vital signs, or put vital signs that have now changed, or put a chief complaint that is just patently not at all what they put, you need to address it, because the EMR does not forget it. If they put that they had vaginal bleeding and they're pregnant in their triage note, you better comment about that. And if the patient says, look, I'm not bleeding at all, I don't know where they got that, people are human. They make errors. Put that in your note. Say, look, I asked this person over and over again, like, have you had any vaginal bleeding? And they said no. I read the nurse's note, and it's not how it is. If they have vital signs, they're just way out of whack, and their heart rate's 40 points higher in triage than what you saw them there, document that you listened to their heart, and their heart rate was normal rate. You know, actually pull out your stopwatch, figure out, oh, look, it was 90 beats a minute. All right, I know that it said 110 in triage, but I'm documenting 90, and I really actually did this. Put where things don't add up. Spell out your clinical reasoning. So one of the things that really drives me nuts, how many times have y'all gotten a note forwarded to you from like another resident to finish up or something, and you read the note and you're like, I have no idea what they were thinking at all. I can tell you attendings get these notes all the time, where a patient that we saw, examined, we could have written our own note, and then you guys send us a note and we're like, I have no idea what they're talking about. I don't think I saw this person, okay? That happens because you're not explaining what you're thinking. Spell it out. It doesn't take that long to put in decent medical decision-making about what you were thinking. Explain, why was it that you ordered what you ordered? Why is it that you did that thing? Increasingly, this is going to be important for billing, because if you don't spell out that they had arm pain and I was worried about a fracture, therefore I got an x-ray, they're not going to pay for the x-ray anymore. That's how it is. And I'll tell you this, if you get in a private contractor group and they're not paying for your x-rays, they're going to get upset for you. And they're gonna get rid of you quickly, and you're gonna get fewer RVUs, and you're gonna die impoverished. That last part, maybe not so much, but the first few, definitely, okay? So spell out why you're doing it. Why was it you got a CBC or something like that? Because if you don't justify these tests, I'm telling you, Medicaid ain't gonna pay for them anymore, okay? What were the scary things that you were worried about, okay? We drill this into you. Think worst first. What is that thing that you're really terrified of? And that chest pain, you're worried about, ACS or PE or whatever. Say it in your note, like I considered ACS, and then I said, well, they got a cough, fever, runny nose, sore throat, I did this or did that, and here's why. Spell it out. Otherwise, when I'm reading your note, I'm like, oh, this guy came in with chest pain, and it never crossed your mind to think of a heart attack. What's wrong with you? Spell out what you did and why you did it, okay? And why weren't you more worried about that particular diagnosis that was scary? Why was it that you didn't think that it was cauda equina when they came in with back pain? Specify it very clearly so that the next person reading your note, be that another doctor or a lawyer, will know exactly what you were thinking. So be aggressive, okay? So you can get people out that are kind of sick by writing good notes. And it's because you don't have to live in fear of lawyers. You just got to document properly so that people can actually go home with slightly scary diagnoses. So document rechecks. So this is one of the biggest things that will save your bacon. If you've got someone and you do a test, and that test could be part of your physical exam, it could be a lab test, whatever it is, an EKG, one test begets another, okay? So you push on their belly and they're hurting in their left lower quadrant or something like that. And you do something else, you order some tests and whatnot, and you decide that you want to discharge them. Why was it that you didn't document that second time that you went in to see the patient and check their belly again? I know that you guys do it all the time because very often you go talk to the patient and say, oh, their headache's better, or their belly pain went away, or they're not vomiting anymore, or their headache's resolved, whatever it is. Put that in your chart. Don't be dumb. Put it down, because that makes it so much better for the next person reading it. This is one of the biggest points from the book Bounce Backs, Mike Weinstock. And it basically encourages you to stop and rethink the cases that are highest risk, okay? So recheck those folks that are higher risk. There are going to be those scary folks that are really going to worry you, okay? That elderly person with just enough belly pain to where, maybe you're getting a CT scan, maybe you're not, maybe that scan's negative. You need to be worried about that person. They're high risk, okay? They're old and they have belly pain. Even if they have a negative CT and you're deciding to discharge them, recheck their belly and document why it was that you're sending them home. but stop and just reassess them globally. There's going to be 2 or 3 patients a shift that you should get worried about, that you realize, okay, it was a young person, a 31-year-old with chest pain. I'm not putting them on the chest pain pathway because of X, Y, and Z. Stop and reassess. And you'll be surprised how often you're like, you know what? This guy looks kind of sick. I'm not done here. Why are they still tachycardic? Why is their chest hurting so much? Is this really chest wall pain? Stop and think about it, and you'll catch stuff. Document shared decision-making. It is really, really hard for a lawyer to successfully sue you if you talk to someone and a patient requests to go home and you document that you talked with them about the different options and they turned you down. And the reason is that it's medical battery if you force them to stay and they don't want to stay, okay? So you can talk to someone and say, look, you're kind of at moderate risk of dying of a heart attack. I would recommend that you come to the chest pain pathway. And if they say no, that's okay, but you need to document why they said it, what their thinking was, and that they're aware of the risks of doing that, okay? This allows you to send people home that are reasonably sick because that's what they want. But you need to have an honest discussion with them and really include them in that decision. Is there someone that's kind of young and you're kind of on the fence about getting a CT scan of their belly or not, but you don't want to expose them to too much radiation? Talk to them about it. Offer them the options of what we have to offer and include them in that decision of, you know, you've got this headache and it's a little bit atypical and I'm not really entirely sure that this is a migraine. I don't think I want to get a head CT and here's why. Let's talk about it and put that in your chart that you talk to them about it. So one of the biggest mistakes that we make as physicians is that we take our values and apply them to our patients inappropriately, okay? So each person in this room has a different threshold of how much risk they're willing to take with X diagnosis, okay? I could walk up to Clay and say, look, I think that right now with the chest pain that you're having from me calling on your name, that there's a 1% risk of you having a heart attack right now. And Clay might say, okay, I'm cool with that. I understand that if I go home, bad things could happen because that 1% of the time something bad occurred, but I really want to go home because I don't want to be in the hospital, okay? And I might, go talk to Liz and say, look, Liz, the chest pain from me calling on you is lower risk for whatever reason, and it's a 0.1% chance that this is actually a heart attack. And Liz might say, whoa, you mean it's a 1 in 1,000 chance that I'm going to have a heart attack? That's way too high risk. That's unacceptable. You got to talk to people to make sure that your values are not what you're basing decisions on, but theirs, okay? So as much as possible, and I get it, we're not fortune tellers. It's very hard for us to walk into a room and say, look, your chest pain, I think it's a 2.3% chance that this is ACS. That's unreasonable, okay? But you can get them a broad idea, okay? You know the folks that you think are really, really low risk, but, they've got a couple risk factors and you're kind of on the fence about it, and you say, look, I think it's less than 1%. Let's talk about it and share that decision, okay? And then you got some folks that are actually quite high risk and they just really, really want to go home. Well, make sure that you tell them and you put it in your chart. It's like, look, I told this guy that's had a prior cabbage and he's got, X, Y, and Z risk factors. I told him that his risk was greater than 5% of this being related to his heart, okay? I told him he understood the risks. He knows that he could die, become disabled. I made it clear that he could come back to me anytime. And I spell those things out. That guy can go home, okay? But you have to talk to people and make sure that you're not applying your values of how much risk that you personally would take about a risk of appendicitis or the risk of radiation from ruling out that appendicitis or the harm of getting admitted to the OBS pathway versus the benefit. Don't use your values, use the patient's values. And the only way that you're going to find that out is you talk to them and you ask them and you give them a reasonable idea of what's likely to happen. Absolutely, because different providers, like if you've been burned by missing a PE, you're going to work up more PEs, okay? If you got a lawsuit because you missed an appendicitis, you're more likely to scan more people because of appendicitis. I'm not saying that you're wrong or right because of that. And you got to be careful, but we're human, okay? And so there are some things that each of us as providers worry a lot more about, okay? Ideally, it would be evidence-based about what is likely to get benefits and harms of doing X thing. But there's a lot of stuff that we frankly don't know. And so if Hartman is more worried about appendicitis than I am, but I'm more worried about PEs than he is, that's okay. That's just because we're different providers with slightly different interpretations of literature, and that's okay. It's really frustrating as a resident to sometimes be surprised that attendings are different, and it's because we're human, and that's okay. But still talk to your patients and make sure that they're aware of their variations of what risks that they're willing to take. And then this is probably the number one thing of this whole talk. This is number one. This will bail you out even if the rest of your note is just horrific. This will save your bacon very often. And that is giving very good discharge notes, okay? You need to tell them very specifically what to do. And I mean very specifically what to do. Because if they don't do that, that offers you at least a little bit of legal protection, okay? If you told them to do X, Y, and Z and come back if X, Y, or Z happens, and then they don't, that offers you at least some legal protection. I'm not saying that there's not lawsuits that happen where you say come back if there's a fever or your cellulitis spreads and it does spread and then they come back and get diagnosed with neck fash that you're not going to get sued. You will. But this offers you a lot of protection, okay? But you have to be very specific. How many of you guys have just relied upon discharge notes without reading them? And you just clicked, oh, it's a URI, and you just click it and then forgot about it, and you didn't tell them when to follow up, and you didn't give them specific reasons to return. We've all done that because we were all rushed, okay? Don't do it. Spell it out for them. Say exactly why you want to come back and be realistic, because otherwise they're going to come back for stuff that you don't want them to come back for. You got to give anticipatory guidance saying, look, you got a URI. It's not going to get better in the next 24 hours. Your kid is likely to remain febrile for the next couple of days. I don't want you to come back just because you gave them some Tylenol and it didn't break their fever immediately. You need to be upfront with what's going to happen, okay? So exactly when should they follow up? Now, some people default to way too aggressive on this and say, all right, I want you to see your primary care doctor tomorrow morning at 9 o'clock for every disease that walks through the door, okay? And they're going to ignore you, okay? If they've got a sore throat, they don't need to see their doctor tomorrow. They just don't, okay? So be realistic. I'm not saying that everybody that comes in with a high-risk condition, you tell them to follow up in a month. Don't. There's room for the return in 24 hours to the ED, or the go call your doctor tomorrow morning because you've got lupus and something weird is going on. That's okay. You can still do that. But it shouldn't be every one of your notes is follow up in 1 to 3 days. It's not the case. There's plenty of stuff that can be seen in 1 to 2 weeks or as needed. Like there are some things that unless you meet one of those other things that I tell you, you don't really need to see anybody for. Who can they follow up with? This is one of those things that Mike Caudell teaches so well. Don't just say like you should follow up the primary care doctor and then not make it a reasonable possibility that they can do it. That's one of the reasons that I spent entirely too long making my discharge sheet of all the resources that you have in the community for these folks to follow up. If they're uninsured and you think that they're just going to call a random private practice and they're going to get seen tomorrow morning, it just isn't the case, okay? And that's actually been shown in the legal climate that if you're giving them unrealistic follow-up instructions, you might as well have told them to do nothing, okay? If you're referring them to ortho and you know that ortho hasn't got a prayer of seeing them, you haven't really done that much for them, especially if you haven't really spelled out what they should do in that scenario. And then be realistic about how they're going to follow up with them. Okay, do they have transportation? Is it likely they're actually going to get in? And I get it that these are things that we can't necessarily fix, but it should make you pause before you're discharging someone that doesn't have any realistic way of getting somewhere. Before you discharge that guy with dialysis that doesn't have a car, and you're saying, oh yeah, you need to be dialyzed in 2 hours. Like, how's he going to get there? At least consider what you can do to offer him, okay? I'm not a big fan of, nanny state. Let's, everybody gets a ride and we're paying for everything. But you need to ponder, like, what is the realistic way that this guy's going to get the care that he needs, or else you're setting yourself up for failure. And then, why specifically should they return to the emergency department? This is so important. You provide them with sharp and as sharp as possible cutoffs. I put, if that temperature is over 101 degrees Fahrenheit, not if you have a fever. Okay, I say if your rash spreads beyond that line that I drew on your leg, come back and see me. If not, don't. Okay, you really got to spell out exactly why you think they should come back. If it's okay for them to have a fever like that cold, tell them the number of days that you think it's okay for them to have a fever. Okay, so it's okay for your child to have over 101 degree temperature, but it better not be for more than 3 days. So if Thursday comes around and your child is still febrile, you either come see your pediatrician or you come see me, okay? I'm a little bit more aggressive about this. The folks that really terrify you, those high-risk folks, if you're working another shift in a day or two, tell them your name and tell them when you're working next. And I like to put that in my chart. It's like, I'm working another night shift tonight. I'm not really sure what's going on with your belly pain. I agree with our shared decision-making that we're not getting a CT scan right now, but I'm not honestly that sure of what's going on with your belly. And I'm up front with them when I don't know. But my name is Dan McCollum. Ask for me out front. I'm working tomorrow starting at 11 o'clock. Okay? And if they come back, be thankful. All right. And that's a hard thing to do, but be glad that they came back because you're the same person. You get to reassess them. Okay. And you're going to already be a step ahead of the game because you know what you already did. You know what you were worried about. It's a really easy note to write the next day. And you should be really glad that they're here. And that's one of those things that in the bounce back book, they really emphasize. If they bounce back, be glad that they bounce back because it gave you another chance to at least make sure that everything's okay. But it is really hard because you see that name pop up on the board and you freak out a little bit. And it's okay, but make sure that you're appropriately addressing whatever it was that you were worried about. So identify discrepancies, clarify your reasoning, spell it out so that if another guy reads your note, you don't look like an idiot. How many times have you looked back at old notes and like, man, what is this guy doing? Don't be the guy that writes that note. Document rechecks of patients, and the more times you do that, the better it looks, all right? If you miss an appendicitis and you document 5 times that you walked in the room and pushed on that belly and it was soft and that there was no pain, you look much better than I checked one time and they had a little bit of mild right lower quadrant pain and I never walked back in the room as far as electronic medical record is concerned. You are sunk, my friend. But if you document again and again, I checked out the person, I shared decision-making, here's why we didn't get a CT scan, you're probably just fine, okay? Share your decision-making with people. And then always be very specific with your discharge instructions.